Hereby I open this academic ceremony in which Karin van den Berg will defend the academic thesis Mental Imagery and Mood Instability in Patients with Bipolar Disorder. May I invite you to present a summary of your study and the conclusions of your thesis.
Geachte prorector, geachte leden van de promotiecommissie, en lieve vrienden, collega's en familie. In de komende 15 minuten ga ik proberen om het onderzoek wat ik de afgelopen 6 jaar heb gedaan in 15 minuten te vertellen. Dus dat komt vast goed. Ik werk sinds 1994 met mensen met ernstige en langdurige psychische aandoeningen. Vooral mensen met psychotische klachten en mensen met een bipolaire kwetsbaarheid. Dit onderzoek ben ik gestart naast mijn werk als klinisch psycholoog op de afdeling psychiatrie en medische psychologie van het Catharina ziekenhuis. En ik heb het onderzoek afgemaakt toen ik ben overgestapt naar het werken bij de GGZE. Ik wilde met dit onderzoek graag een bijdrage leveren aan het verbeteren van de behandeling voor mensen met een bipolaire kwetsbaarheid. In de afgelopen tijd is er een enorme verandering geweest in hoe wij over psychose denken. Psychose, daar bedoelen we mee het horen of het zien van dingen die er niet zijn, of het hebben van denkbeelden die afwijken, zoals achterdocht. En vroeger noemden we terugkerende psychose schizofrenie. We weten nu dat schizofrenie niet bestaat en geen chronische breinziekte is, maar een manier waarop mensen klachten krijgen als het allemaal te veel wordt. En deze manier hangt voor een belangrijk deel samen met trauma en andere nare levensgebeurtenissen. Door deze nieuwe manier van psychose begrijpen, zijn er enorme verbeteringen mogelijk geworden in de psychologische behandelingen. Cognitieve gedragstherapie, hebben jullie vast wel eens van gehoord, is een van de meest bewezen en meest gebruikte en meest bewezen effectieve psychologische behandeling. En deze behandeling is op maat gemaakt met behulp van deze nieuwe manier van psychose begrijpen. En daardoor hebben we de effectiviteit van de behandeling kunnen vergroten. Wat zou het nou geweldig zijn als we hetzelfde konden doen voor een bipolaire kwetsbaarheid? Als we dat beter kunnen begrijpen. En zo ook de cognitieve gedragstherapie kunnen verbeteren. Hiervoor is verder onderzoek nodig naar de werkingsmechanismen van stemmingsinstabiliteit en angst bij mensen met een bipolaire kwetsbaarheid. Dus waarom gaat eigenlijk de stemming op en neer? Wat is eigenlijk een bipolaire kwetsbaarheid? Phil Alsop die vergelijkt een bipolaire kwetsbaarheid met het koken van melk. Te veel energie en alles loopt over. Weinig slaap, snel denken, soms psychotische klachten, impulsief zijn, grootse plannen. Maar te weinig melk, te weinig energie en de melk blijft koud. Er gebeurt niet zoveel. Sombere stemming, moeite met activeren, geen licht aan het einde van de tunnel zien. En traditioneel wordt een bipolaire kwetsbaarheid ook een bipolaire stoornis genoemd. En dachten mensen er eigenlijk hetzelfde over als schizofrenie, een chronische breinaandoening. Maar is dat eigenlijk wel zo? De richtlijn behandeling voor mensen met een bipolaire kwetsbaarheid is het behandelen met lithium, een medicijn om de stemming te stabiliseren. En behandelen met psycho-educatie. Dat is informatie geven over de ziekte en over wat je kunt verwachten. Eigenlijk ook een manier om mensen te leren omgaan met de gevolgen van deze problemen. En ook een manier om te proberen om de stemming zo stabiel mogelijk te maken. Ondanks deze behandeling, ondanks deze richtlijn, blijven mensen last houden van wisselingen in stemming. Zijn mensen die blijven terugvallen in episodes van manie en depressie. En er bestaat een gedeelde visie eigenlijk, onder eigenlijk alle klinici en onderzoekers, dat er behoefte is aan meer effectieve behandelmogelijkheden om de stemming stabieler te maken. En om ook de gevolgen van de behandeling nog verder te verminderen. Als we nou kijken naar andere psychische problemen, dan zien we dat in de afgelopen decennia er heel veel verbeteringen zijn gemaakt. De cognitieve gedragstherapie is voor veel mensen veel effectiever geworden door het toevoegen van imagery technieken. Misschien hebben jullie wel gehoord van EMDR. Tegenwoordig gebruiken wij EMDR, dat is dat zwaaien met je vingers, bij traumabehandelingen. Maar we gebruiken ook andere imagery technieken zoals rescripten bij angst. En er zijn nu eigenlijk ook suggesties dat misschien is het voor mensen met een bipolaire kwetsbaarheid ook wel mogelijk om die behandeling, de cognitieve behandeling, effectiever te maken door imagery technieken toe te voegen. Maar wat zijn imagery? Wat is imagery eigenlijk? Nou, Homer die kan als hij denkt aan zijn lievelingseten, dan kan hij denken aan donuts in woorden. Maar hij kan het ook voor zich zien. Hij kan eraan ruiken aan die donut. Hij kan eraan likken. Hij kan er een hapje van nemen, mee gooien. En al die manieren van denken, dat noemen we imagery. En we weten dat deze laatste manier van denken meer de aandacht trekt, een groter effect heeft op emotie en op gedrag dan het denken in woorden. En misschien is dat omdat deze manier van denken dezelfde hersengebieden gebruikt als echt waarnemen. Het wordt ook wel eens weak perception genoemd. Dat denken in beelden, of imagery, dat is niet één concept. Daar zitten een heleboel verschillende aspecten aan. Zo is het belangrijk om te weten hoe vaak iemand eigenlijk in beelden denkt. Het is ook belangrijk om te weten hoe levendig dat beeld is, in welke mate het de aandacht trekt, het je wil overtuigen. Maar we willen ook weten wat dat beeld betekent, wat je meteen daarna denkt. Bijvoorbeeld, ik zie dit nu voor me en dat betekent dat ik een loser ben. Of ik heb dit nu gezien, dat betekent dat ik ga terugvallen of dat er iets heel naars gaat gebeuren. Omdat die verschillende imagery technieken, waar ik het net zo in vogelvlucht overheen ging, op verschillende aspecten van dat imagery werkt, is het heel belangrijk, als wij de behandeling willen verbeteren, dat we ook onderzoek doen naar die verschillende aspecten van imagery bij mensen met een bipolaire kwetsbaarheid. Om dat te onderzoeken hebben wij een online survey, een online vragenlijst gemaakt. En die hebben wij gebaseerd op het standaard interview wat er normaal gebruikt wordt van Anne Hackman, het imagery interview. En om te kijken of we dit konden gebruiken, deze vragenlijst, hebben we hem eerst afgenomen bij 134 gezonde studenten. Nou, deze vragenlijst bleek betrouwbaar, valide. Het bleek ook eigenlijk best die verschillende aspecten van imagery goed te kunnen meten. En ook het effect van imagery op emotie en gedrag. Vervolgens vergeleken we mensen met een bipolaire kwetsbaarheid met groepen die vergelijkbaar waren in hoeveel beelden ze, in welke mate ze in imagery dachten, in beelden dachten. Met creatieve studenten, zonder stemmingsproblemen, maar we vergeleken deze groep ook met mensen die wel vergelijkbaar waren in stemming. Bijvoorbeeld mensen met een unipolaire depressie, een gewone depressie. En deze drie groepen die vergeleken we weer met een gewone gezonde controlegroep die niet bepaald in beelden dachten en ook geen stemmingsproblemen hadden. Nou vonden wij dat zowel de bipolaire groep als de mensen met een unipolaire depressie en de creatieve studenten die heel veel in beelden dachten, maar geen stemmingsprobleem hadden, dat die iets gemeen hadden. En namelijk dat ze allemaal evenveel in levendige beelden dachten en significant meer dan de gezonde controlegroep. Wat we wel vonden is dat van binnen die groep van mensen die vaak in levendige beelden dachten, dat er een verschil was tussen de mensen met een stemmingsprobleem, die mensen met een gewone depressie en een bipolaire stoornis aan de ene kant, en de creatieve studenten die veel in beelden dachten, maar geen stemmingsprobleem hadden. En dat verschil was de onmiddellijke gedachte die ze hadden over dat beeld. Als je vervolgens binnen de groep kijkt van de mensen met een bipolaire kwetsbaarheid, dan blijkt dat de mensen die stabiel zijn niet te onderscheiden zijn van creatieve studenten die ook veel in beelden denken. Alleen de mensen die op dat moment manisch of depressief waren, daarbij had het denken in beelden een heel groot effect op emotie, maar ook op gedrag. Nou, de volgende stap was, om dat imagery in deze groep mensen met een bipolaire kwetsbaarheid beter te onderzoeken, was om te kijken of deze manier van denken, imagery, door de tijd heen ons kon vertellen. Wat gebeurt er nou eigenlijk eerst? En daarom volgden we 62 mensen gedurende 33 weken. En elke week meten wij de samenhang tussen denken in imagery, tussen angst en manie en depressie. En we vonden dat zowel imagery als angst centraal stonden. En dat een toename van imagery en een toename van angst vooraf gingen aan een toename van symptomen van manie en depressie. Dit ondersteunt de theorie van Emily Holmes. Zij stelde voor dat imagery in de groep van mensen met een bipolaire kwetsbaarheid werkt als een emotionele versterker. We vergeleken verder, in een andere studie in dit promotieonderzoek, vergeleken wij een groep mensen die de reguliere behandeling kregen, medicatie, maar ook groepspsycho-educatie, dus informatie over de ziekte en manieren om ermee om te leren gaan, met mensen die een andere soort behandeling kregen, namelijk een cognitieve gedragstherapie die vooral bestond uit imagery technieken, IMCT noemen we dat. Deze behandeling is ontwikkeld door Emily Holmes, Carrie Young, Susie Hales, Martina Di Simplicio. En we gebruikten het protocol wat zij ontwikkeld hebben. Wij vonden dat deze behandeling net als psycho-educatie de stemming stabieler maakte. Maar dat in de groep van mensen die de IMCT, die nieuwe CGT kregen, de angst en de depressie significant meer daalden. Ook de hopeloosheid nam meer af. En dat is heel belangrijk, want we weten dat hopeloosheid samenhangt met suïcide. Wat ook belangrijk is dat eigenlijk de meeste psychosociale behandeling deze effecten gewoon helemaal niet hebben, ook niet op manie. Dus dit is al met al een hele veelbelovende nieuwe behandeloptie voor deze groep. Tijdens deze studie waren er een aantal mensen en die waren manisch geworden. Dus we includeerden ze. Ze werden voor de start van de behandeling behoorlijk manisch. Normaal gesproken worden deze mensen niet meegenomen in een studie, maar wij hebben dat wel gedaan. En we hebben ze in de studie gehouden en over een van die mensen hebben wij een case report geschreven. We merkten dat deze mensen enorm veel baat hadden bij deze nieuwe cognitieve gedragstherapie. Ze konden heel goed meedoen, het afmaken, gebruik maken van de technieken. En we hebben ook gemeten en gezien dat die symptomen van manie significant afnamen. Achteraf hebben we deze persoon ook gesproken en die gaf ook aan dat hij er veel baat bij had, vooral van de stoelentechniek. Dat is een van die imagery technieken. Al met al is het dus heel erg belangrijk en is deze nieuwe manier van bipolariteit onderzoeken echt heel erg nodig. Het is geen breinziekte, maar een ontregeling die samenhangt met angst en mental imagery. En misschien nog met andere factoren, maar in elk geval met deze. Bij onderzoek naar deze groep mensen is het heel erg belangrijk om mensen die op dat moment manisch of depressief zijn, wel te includeren. Als je namelijk alleen de stabiele mensen meeneemt in onderzoek, verkleurt dat dus je vindingen enorm. Want deze mensen zijn eigenlijk niet te onderscheiden van stabiele studenten die heel veel in imagery denken. We denken ook dat vooral de onmiddellijke gedachten die samenhangen met dat beelddenken heel erg belangrijk zijn. Deze onmiddellijke gedachten die hangen mogelijk samen met eerdere ervaringen en misschien trauma's, net als bij psychose. We vonden dat IMCT, de nieuwe cognitieve gedragstherapie met heel veel imagery technieken, eigenlijk een hele flexibele behandeling is die op maat gemaakt kan worden per individu. En eigenlijk ook dat deze heel veelbelovende resultaten heeft, ook voor mensen die manisch zijn. Wie weet helpt deze nieuwe kijk op een bipolaire kwetsbaarheid. Wie weet helpt deze nieuwe kijk op een bipolaire kwetsbaarheid en deze onderzoekslijn wel voor een vergroting van de effectiviteit van cognitieve therapie voor deze groep. Net als we eerder gezien hebben bij psychose. Bedankt voor de aandacht. Ik geef het woord terug aan de prorector.
Thank you for your presentation. The opposition will be opened by Professor Dr. Rijkenboer, Professor of Clinical Psychology from Maastricht University.
Dear candidates, it was with great pleasure that I read your dissertation. Beautifully written, very clear, and nice studies as well. Beautiful pictures as well. So I want to congratulate you and your team for this wonderful book. And I read it because what is most important is that you really have a passion for this disorder. And so you developed a certain technique. Actually, Emily Holmes, Professor Holmes developed this technique, but you tested it critically. And considering the following thing, I wanted to discuss with you the cost effectiveness, actually, because at the moment in the Netherlands, costs are rising, and I don't think it's only in the Netherlands, but here it's a pressing problem. So actually all the new things that we are going to implement actually should be worth the money, because otherwise, you know, costs are going to rise even further than that. So I read your chapter 5, in which you described this ICT. And what I understand is that the imagery-focused CBT is being provided by highly experienced clinical psychologists and psychotherapists. And what I understand, it's being provided individually, individual therapy, whilst the psychoeducation is being provided by health nurses in a group format. And that actually means that this psychoeducation program costs far less than the imagery treatment. Do you think it's worth the money, considering your results in this ICT?
Highly esteemed opponent, thank you for your question. This is actually a very important point. Costs are rising, and we do need to be very mindful of that. The costs of this illness, of this disorder, are huge. The expenditure of being off work, being decompensated and requiring a full team, they are very high as well. This thesis didn't study the cost effectiveness, but I do think that future studies should be mindful of that. But I wonder if it is that more costly. I think if people are becoming manic, there is very little psychoeducation can do. And people do relapse despite the psychoeducation. We did find, however, not in this study, but while conducting this study, that people, that the team members, so not just the psychologists, but the nurse, specialist nurse in our team, they used the things we used in the IMCT. And maybe, and this needs to be studied, obviously, we cannot say this for sure, but it could well be that if you take that into account, that there is transference to the rest of the team for relapse prevention. We do have a film that we make at the end of the intervention that is shared with the other members of the team, with family members. If you involve them, it could well be that the manic episode can be curbed sooner. And if that is true, then the saving of costs are huge. There is another thing that I was just thinking about. We are, and again, this is not studied and beyond the scope of my dissertation, but we were very interested to find out if this intervention can also be delivered in a group. And a colleague of mine, Ingrid Albers, and I have conducted a sort of experimental group. We did find that this is a very interesting topic and maybe promising. So future research needs to look at the expenditure of how much does this intervention cost, how much does it yield for services and for society. But there is also scope to study the effects of group IMCT.
Yeah, but if I would like, considering the results of your study, actually there's not a lot of difference between the psychoeducation module and the imagery module. So, and you did a lot of comparisons.
Yeah.
But you choose not to correct for those multiple comparisons. So you did not adjust the alpha level. If you would have done that, there would have been hardly any difference between these two. And is that worth all the money?
I am not sure if we didn't correct for that. We did linear regression models.
Yes.
And looking at the daily measures, there was a significant difference, which was beyond doubt. On the weekly measures, we did not find the same. You're right, we did not find as promising differences.
But the alpha level, for example, if you look at page 107, for example, depression, there is a significant interaction effect for depression in the sense that imagery CBT is doing better than PE. And the alpha level is, the alpha value, the P value is 0.39. And if it would have been corrected, then this would not be significant, for example.
The way these analyses work is that you have you see if there is a fit, a reliable fit of this model that you create. Now, then you add intervention, and not different interventions, but then you see if there is a difference before and after in these, especially changes. And by adding an extra factor in the model, if it's not more reliable, then that extra factor doesn't contribute anything. Now, that way, you add after that an extra factor, which is the condition. And we did find that there was a difference between these two conditions if you did that. But there weren't that many other things to divide the alpha by. We only had this. Okay. So I do think...
so you conclude it's worth the money?
I do. But I do agree with you that we do need to be very mindful of that. Yeah.
Okay, thank you so much.
Okay, thank you. Then we go to our online guest, and the opposition will be continued by Professor Dr. Holmes, Professor of Psychology of the Uppsala University. And I hope you can hear as well.
Very well, thank you. Dear candidates, congratulations. It's a pleasure to read your thesis, and also a pleasure to see the beautiful images that you have put within it. Reading it, there are so many elegant parts, but also very pioneering parts. And this, for any of us who've worked in the area of bipolar, know it's not an easy group to work with. Also, what you've done is work with people of the most difficult characteristics, often excluded from trials, including those becoming manic and those who are suicidal. And I've been really interested to read the many different ways that you've approached this topic, from method to clinical practice. And with this research and the many outcomes that one can apply, and I guess with bipolar, one of the critical issues in the field has been, it's not easy to say what the best outcome is, because is it stability, is it functioning, it's a life course disorder like diabetes. I'm trying to be curious really around your views of who might this help and when, and by whom I mean which types of people with bipolar disorder might be benefit the most, and when, I guess I wondered if you had any thoughts about when in someone's illness history this might be most useful to apply. I'm very curious for your thoughts.
Highly esteemed opponent, thank you for your kind words. If I understand your question correctly, you would like to know who would benefit most from this study, from this intervention. I did not do any analysis on that, so I would need to speculate, as I was one of the clinicians in the trial, and we did have the online supervision and lots of thinking about the fine-tuning of this intervention. We did have some ideas about that. And we actually found that if people were more unwell, either more manic, more depressed, more anxious, or had more mood instability, they seemed to benefit most. When people were more stable, but more included in the study because they had mild variations and they wanted to learn more about how to manage it, they benefited too. But we did see the most striking things happening with people who were very unwell. So I don't know why, but it does seem to help more for those people. And it does, I did wonder whether it would be sustained. As a clinician, speculating, I don't know, they didn't study this, but I have a feeling that if you put an extra focus on the relapse prevention in the film, not just with the client, but also with their relatives, people living with people, and especially the other members of the team, and you can continue an attention for factors and images that contribute to mood instability, anxiety, and mania and depression, I hope that it will be sustained.
That's really helpful as well. So that suggests that perhaps one of the things in one of the future aspects for research is to extend the time frame for outcome measure collection with a focus on relapse prevention, if I understand you correctly. And in that light, I also wondered, and this is beyond the research, but perhaps the detail of you running the trial in these videos, or when you work with people, what are patients with lived experience with bipolar disorder themselves saying about this approach? Because I guess coming from the theory that you've presented in your introduction, humans can think in two ways. We can only talk in words, or we can talk in images, and it's not so. If we ignore people's images, that's fine, as we do in most. But maybe they can be honest. But what do people themselves say when you start to bring this in? And is there anything once they've been through your treatment they're saying that you think could help your future research or future patients with bipolar in terms of this particular imagery approach, and also whom it might benefit the most?
That's a very interesting point, because we didn't analyze the qualitative stuff, but we did interview everyone that went through the trial. And a lot of people made spontaneous comments about having this treatment. And I clearly remember at least 2 or 3 people who told me, I've had many runs of CBT in the decades past, but this seems like a language that it suits me better. It's almost like talking in images is a language I better understand, and I do seem to benefit more because it is my language. Now, I did, in my regular work, before I started this PhD, I didn't routinely ask for images. So if I, as a trained CBT clinician, would talk to clients and patients, I would ask them questions. But now, after having done this study, I routinely ask for images. And I was surprised how many people actually report disturbing, intrusive images that are recurring and are affecting how they feel. It's just not something that people routinely report spontaneously. So this combination of it being a language that suits better, in combination with, as clinicians, we should ask more about it. I think there is a whole field to discover, especially for this group.
That's really helpful. And I guess we do live in a very logocentric world, as in a word of words. So hoping, so this visual language aspect that you're saying qualitatively might be the sort of thing that you could explore in the future. For example, seeing if those most experiencing imagery or needing to understand how a visual language works, perhaps that might be something that could point towards who might benefit the most as well.
And then ask for images and see what the differences are. That's a whole new area to study, yeah.
Yeah, I think this, well, anyway, I just think your work opens up so many interesting new questions, and thank you so much for letting me explore these questions with you.
Thank you.
Then we can continue with an online guest, and the opposition will be continued by Professor Kupka, Professor of Bipolar Disorders of Amsterdam University Medical Center.
Thank you very much. Dear candidate, I have been following your research over the past many years and congratulate you with the results of the completion of your studies, because it is very important to study the psychology of bipolar disorder. If you don't mind, I say disorder because I think it's a disorder. We might discuss that in another time. But now I want to discuss with you what you found in chapter 4, especially what is reflected in figure 1 on page 82, and also in chapter 7, figure 2 on page 148. And there you visualize that mental images may lead to anxiety, and anxiety may lead to depression or mania. And what puzzles me as a clinician is why in some people anxiety would lead to depression, which I can imagine, but in other people anxiety would lead to mania. So what makes this difference? Can you explain that?
Highly esteemed opponent, this is a very good point that I'm not sure I completely studied in this chapter or in the dissertation, but I do have ideas about that.
Please.
Um,
I'm very anxious to hear your ideas about that, because you didn't explain it in the study. I'm aware of that, but you must have thoughts about it.
I do, yes. We couldn't study that in more detail. And if we would do future studies, I would want to measure daily or multiple times a day and ask questions exactly such as this. But while analyzing the data and also talking to a lot of people about images and the effect it has, I do feel that if you become more anxious, it can have a relationship to both mania and depression. It could be an anxiety about a pending fear of relapse. For example, I have one boy who had a good day and he came back on the train, he felt happy. And that instantly triggered images of him being manic and being admitted under a Section 3 under the Mental Health Act with lots of problems. So even though he had a small, tiny change of a normal mood change, it triggered an image of him being admitted, which triggered depression. But it could also be the other way around. If you become manic, it's not just happy feelings not for everyone, but a lot of people. The excitement that you feel with mania is often accompanied with anxiety, with a sort of sense of losing control. Now, when we did the case study on mania, our participant described really well a vivid image that was accompanied together with anxiety and mania. He described an image of him being on a bus without a driver, and the bus was just going out of control, wildly steering, sort of a Speed 2 film, and that caused a lot of anxiety. And not even just the thought of him relapsing, but being out of control. And this sense of out of control can go hand in hand with an increase in mania symptoms. Now, this is one example.
If I may interrupt you, I understand that mania is not a very pleasant situation. So it might give very negative images. But still, why, if that invokes anxiety, why would in some people it lead to depression, to a depressive state, and in other people it would lead to a manic state? That is what's puzzling me. You can also be, depending on a past experience of mania, you can become anxious and then become depressed. But why would you become manic at the time?
Yeah, this is the difficulty. Images are highly individual, and so is anxiety. We don't really know what is exactly the sequence, but what we did find is that this specific sequence was very, very individual. So for other people,
maybe we can discuss this. What I would think that somebody who has a subclinical manic state already will have an image about what she explained, and then it would be leading to anxiety, and then it would be make him manic because he was already a little bit manic, or he can be already a little bit depressed. So it may be a circular process of a mood state which is amplified by anxiety. But then the puzzling state is, why is somebody in this subclinical manic state? I know that you can't solve this difficulty, but it puzzles me why people get manic or why they get depressed. And I appreciate that anxiety will exaggerate all kinds of mood states. But still the question is, and that is why I call it a disorder, why people get manic. And that is maybe, if there's some time, in your propositions, in English, you use the word bipolar disorder 8 times, but in the Dutch, you use the word bipolaire stoornis, bipolar disorder 2 times, and bipolaire kwetsbaarheid, bipolar vulnerability, the other times. So what's the difference? In English, a disorder, and why in Holland it is a vulnerability?
Well, this is also a good point. I do think it's we don't know, and that's probably why I use the terms interchangeably. I do tend to incline towards that maybe it's more of a way of decompensating that is biologically predetermined. And that's why I'm inclined to think of vulnerability rather than disorder. However, the truth is we do not know why mood goes up and down. We do not know why lithium works. There's a lot of unknowns in this mood fluctuations. My study and other studies, we think that at least part of why it happens has to do with images anxiety, and especially these metacognitions, which are related to learning experiences. And early childhood traumas of adverse life circumstances, or core beliefs, the way you learn to look at yourself, that highly influences the mood state that you're in. So it's not just biological. There are many other factors that we need to look at. And this is the key thing. We want to know why it happens. I do think this is a...
We can agree about that. It's not only biology. But I think it's not only psychology also. So we may meet in the middle in the future. Thank you very much for your answers to my questions.
Now we can continue the opposition by Professor Peters, Emeritus Professor of Clinical Psychology from Maastricht University.
Dank u wel. Met uw toestemming neem ik de vrijheid om de oppositie in het Nederlands voor te zetten, omdat u ook uw presentatie in het Nederlands had. En ik denk, nou, ik ga toch gewoon vragen of de rector het goed vindt. En ik zie geen protest. Kan ik een van de... Nee, ik ga eerst de complimenten met uw prachtige werk, voor alle duidelijkheid. Maar dat hou ik heel kort. Dat gaan we straks nog wel doen, gezien de tijd. En ook mijn complimenten aan uw supervisor. Want jullie hebben een fantastische studie gedaan met hele mooie resultaten. En heel intrigerend. Ik zou een van de paranimfen willen vragen om stelling 7 voor te lezen. Wie gaat het doen?
En ik heb de stelling in het Engels.
Dat mag ook.
Ja, om het even af te wisselen. Cognitive behavioral therapy with an imagery focus, IMCT, is more effective in reducing symptoms of depression and anxiety than psychoeducation in individuals with bipolar disorder.
Super, dank u wel. Ik denk... En dat is al een beetje aangestipt door mijn collega Rijkenborg aan de overkant, dat u uw resultaten een beetje aan het overcellen bent. U maakt ze te groot. Want dit zijn kleine verschillen die u vindt, maar op de main outcome vindt u eigenlijk gewoon geen verschillen tussen psycho-educatie en uw behandeling. En dat sluit aan bij het feit dat we weten dat een heleboel behandelingen allemaal even effectief zijn. Op depressiegebied geldt dat, en dat geldt natuurlijk voor de psychosociale of psychotherapeutische interventies bij de bipolaire stoornis ook. Dus ik ben heel benieuwd waar u uw optimisme op steunt, dat u denkt dat dit echt effectiever is. Want we weten uiteindelijk, de Doderbirds verdict laat zien dat alles even effectief is. En u heeft nu 1 studie, er was een andere studie die u aangaf, waar geen verschillen zaten. Dus waar komt uw optimisme nou vandaan? En ik hoop dat u kort kunt antwoorden.
In het Nederlands of in het Engels?
U mag kiezen.
Doe wat het prettigst voelt.
Highly esteemed opponent. This is a recurrent question. We talked briefly about that in the other question. And you're questioning whether the IMCT is not, whether I'm not overselling it and whether it might be less effective.
Equally effective.
Equally effective. Well, this is the thing. We didn't find all that many, in other studies, we didn't find all that many effective results for CBT. There are very mixed results. It is certainly a very important addition. But we don't find the same results as we find, for example, in psychosis or OCD. Now, in our study, we did find a result, and Berg is someone who studied, for example, CBT in bipolar disorder. He found that if you have 20 sessions of CBT, it was as effective as psychoeducation. I know my study didn't compare the results to Berg's, but this certainly is very promising, because this is in a number of aspects as effective, but in some aspects more effective.
Mm-hmm.
Now, the areas where we did find a more effective result was especially in the daily measures. And I think a lot of researchers have regrets of the way they conduct studies. I certainly, with hindsight, regret not doing more daily measures and perhaps multiple days. We found that for people, weekly measures, looking back over a week, reporting small changes in mood is very difficult. Despite that, we didn't find that many differences in the weekly measures, but we certainly did find them in the daily measures.
Oké, dan ga ik u even onderbreken. Had u dan niet een ander design moeten nemen en eigenlijk niet met psychoeducatie moeten vergelijken, maar gewoon klassieke CBT en enriched CBT met imagery? Want dan zou u echt weten of daar wellicht in dat aangrijpingspunt, wat u veronderstelt, dat daar een verschil zit. Dan had u toch eigenlijk een andere controleconditie moeten nemen?
This is certainly the next step, I think. This IMCT is quite new. It was piloted in a study by Susie Hales and audited in another study by Martina Di Simplicio. In small studies found to be feasible, and there were suggestions that it was an effective treatment. But before you do a large RCT comparing with CBT, the next step we felt was to compare it with treatment as usual. What is in the guidelines is medication, but especially group psychoeducation. So we felt that the next step in seeing if this study is feasible and effective would be to compare it with treatment as usual, which is what we did. We are now talking in an international research group of how could we do exactly this. What is the next step is compare it to CBT in a larger trial across countries, and then I think change the measures in a way that we can be more sensitive to the changes that we're trying to measure.
Oké. Ik zou dolgraag met u doordiscussiëren, maar de tijd gaat keihard, dus ik geef het woord, dank voor uw antwoorden en ik geef het woord terug aan de prorector. Dank u wel.
Thank you.
Dank u wel voor uw bondigheid. Dan wordt de oppositie... Oh, sorry, now I switch in Dutch as well. The opposition will now be continued by Professor Marcelis, Professor Transdiagnostic Psychiatry of Maastricht University.
Thank you. Dear candidate, I also would like to express my congratulations and my compliments for the nice work you did. I think it's a very valuable piece of clinical research that deserves full attention, also in novel research plans. And in the end, I think it may help, if really cost-effective, etc., help maybe some individuals choose for a modular treatment in a broader context, informed treatment strategy. And compliments for the pioneering role in the Netherlands on this topic of imagery in bipolar disorder. That deserves a lot of stamina, especially when you are a busy clinical professional, so I'm proud of you. I also want to address some questions, of course, about your thesis, and following up on some questions of the colleagues already. I was wondering, in the result of chapter 5, where you compare the PE and the IMCT, I would like to dig into a bit more in, it's already been mentioned, okay, there is not a big finding on the primary outcome. And yes, there are some findings in the secondary outcomes, but I would like to try to understand that. So what are the explanatory variables behind that? I thought that you wrote maybe we had a very a bit special PE group with some aspects that is not there in the standard PE group. So I was wondering what that exactly is, or are that just non-specific factors or generic factors? Maybe you can answer that first, and then I have a follow-up on some alternative explanatory variables that I think may have played a role here.
Highly esteemed opponent, thank you for your kind words. You're asking, can I explain, can I say something about the group psychoeducation? Why is it this effective? This was a little bit puzzling for our research group as well, because we know that, for example, the dropout rates in groups like this is normally around 14 to 17%. Our dropout was only 3%. We also found that it was effective in curbing mood instability. Other studies don't find that either. Fortunately for the patients, this was a very effective group psychoeducation. A little bit unfortunate as a researcher when you're trying to explore the differences. I do think that the bipolar team that I am working with this study in the GGZE is quite exceptional, actually. The people that are doing the PE have been doing this for a long time. They're highly trained. We also compared our service with within the intervention group that we had with the external supervisors in the UK. We found that our team was much fuller. We had more specialist nurses, we had more trained nurses, we had more psychiatrists, we had more time and resources than the teams that the other people were working in.
Okay, that might.
So it might be that this is a factor, but I don't know.
I understand what you mean then on that level, yeah. But if, for example, there was a less than expected result in the IMCT group, what other explaining factors? For example, in page 102, I see there are some group differences on the level of like medication use, the mood stabilizers, but also illness duration, number of admissions.
Yeah.
And they seem to be, it looks like that there maybe is a bit more severe, you investigated a bit more severe group in the IMCT group. And perhaps a bit milder group was the PE group. Could that, do you agree on that? Or how could that have influenced your results?
I do think that is the case. We found, for example, that in the IMCT group there were more admissions, and other studies suggest that if you have had more than 11 episodes or multiple admissions, therapy is less effective. I don't know whether that is actually true or whether this explains anything. The other differences weren't significant, but we did find, if you look at not at the significant levels, but at the number of admissions and medication, we did find that the IMCT group seemed more affected. Mm-hmm. So that could be it. I don't know if that is a factor, but it could be. So that we have two explanations. Either this is psychoeducation nurses that did the group were highly trained, very experienced, and more resources, but also this group, the IMCT group, could be more affected or more severe.
Yeah. And then it's the question if it was, you before you said, I also had you had the feeling that it was in clinical practice more effective in the severe group.
Yeah.
But I think that is really nice to further investigate and to get really that we get to know what was this a fair comparison, or you can do a better comparison, and then there is chances for even maybe more effectiveness than you could have found now.
Definitely, because the variation was quite big, and we had people in the IMCT group that were already quite stable, and we did. Our impression is that the more unstable, the more symptoms you have, the more effect you see with this treatment. Mm-hmm. So if you do future research, it would be good to tease that out.
Thank you very much.
Thank you.
Thank you. And then the opposition will be continued by Dr. Koenders, Assistant Professor of the Department of Clinical Psychology of the University of Leiden.
Thank you. I also want to congratulate you on your wonderful thesis. I'm always very impressed if people dare to do a randomized controlled trial, especially in a group of this kind of severely ill patients. So, well, congratulations on that. Of course, I also have some discussion points. And sitting here for 45 minutes now, I think we also have some kind of bipolar situation during this defense. And I think that the defense committee is a bit more on the depressed side. And you are a bit more on the manic side, if we look at the thesis. And I want to invite you a little bit on the depressed side, maybe. Because we all talked about, okay, what do these results mean that you have found? And can we be very happy about it? And is this a very positive and hopeful finding or not? And if I look at your findings, then, well, if we have a patient and we would recommend this treatment, we would say, okay, if you follow this treatment, on average, you will have a drop of 2 points in your depression score and of 1 point in your mania score, which is not a very hopeful message, I think. And looking at the RCTs that has been done now in bipolar disorder psychological treatments, we do see that these effects are very limited in bipolar disorder. And could you try to formulate a hypothesis that would say, okay, maybe psychological interventions will never have very big effects in this specific disorder? Could you formulate a hypothesis that explains that? Why? Why is it so ineffective, actually?
Esteemed opponent, this is a very difficult question. There are two sides to your question. You're talking about the results. You're also asking me to think with you about why do we not have the answer and a similarly effective treatment like we have, for instance, in OCD. Mm-hmm. First of all, the 2-point drop, that was actually really substantial because the scale was only 4. So symptoms.
No, the scale of the kids is 27, the maximum score.
Oh, you're looking at the weekly measures. Oh,
yeah.
Okay. Yeah.
Yeah. On a daily measure, it's even less. It's like 0.2, the drop.
The drop in the daily measures was substantial. It's difficult to see in the results mm-hmm. because of the scales. I do feel that the weekly measures are. I would not use them if I did another study. I would really look daily and multiple times a day. Maybe we can talk about that another time more in depth in the analysis.
But I'd still like you to formulate, should there be a reason why these treatments are less effective in bipolar disorder specifically? So I know you're very, you should be positive about this whole study and everything, but I also want you to think about, okay, but aren't we overestimating or too hopeful about the effects in this specific type of disorder or vulnerability, what we want to call it? But
yeah, I think that's a difficult question, and it would mean me really speculating because I don't know and I didn't study this. But I have a feeling we really do not understand completely why mood fluctuates. And I have to admit, with our study, we're only tapping into one other aspect, which I think is important. We do need to look more individually in core beliefs, learned experiences, traumas. I mean, up to 80% of this group have had trauma in their past. And we ignore that. We look at mood problems and treat them with medication or one standard intervention. We don't do that when we treat trauma. We don't do that when we treat psychosis, but we still do that in bipolar disorder. So I am with you worried that we will not find one answer to treat everyone. There is no one size fits all, and we're not going to find one size fits all psychology treatment. But I do hope that this research and this way of exploring factors that may contribute to mood going up and down will lead to a better understanding, which this is not the end answer, but in the future we will take more factors into account. And I do think that we need to look at these core beliefs and traumas as well. I'm also in another research group in imagery and psychosis, and there, because of the emphasis on trauma, we have different discussions now than we had 10 years ago. I do not know what the discussion would be like in our field, but I have a feeling that if we take an example from what's happening in that group, maybe we will get a better understanding and get a psychology treatment that does not fit for everyone, but will be more effective than what we've got now.
Okay, thank you. And it's a good display of how difficult it is to change core beliefs, maybe.
Definitely.
Yeah. Okay, thank you.
And then we will continue online, and the opposition will be continued by Dr. Krantz, Assistant Professor of the Department of Clinical Psychology of the Radboud University.
Dear candidates, I do have a minute to congratulate you with your focus. Which are really excellent, with a very strong outline and a clear scientific as well as clinical impact. So it shows to me that you're a true expert scientist practitioner. And I've met you once only, but I also think you're a very nice person, which is not unimportant either. So congratulations to you and your team. I guess my question is a little bit smaller, sticks a little bit closer to your research. Maybe that's nice to end off with, I don't know. But on several occasions in your thesis, and not the least occasion, so it's on the cover, mental imagery and mood instability. You mentioned mood instability as the main target of for intervention in bipolar vulnerability or disorder. And your general discussion even starts with the line, the series of studies in the present dissertation explored the role of emotional mental imagery on mood instability in patients with bipolar disorder. So I have two questions about this mood instability. So to me, it did not become entirely clear what you mean by it. You define it as small changes in self-rated depression and mania, rather than full-blown episodes of mania and depression. But how small are these small changes until they become normal changes in mood that we can all experience? So what is the difference there exactly? And my second question is, how did you, or maybe you did not, measure mood instability in your studies? And I guess in response to Professor Peters, you already said something about that. So you measured mania and depression, but I didn't really see a measure of these small changes. And I also wondered how you measure that. What would be a cutoff for being in stable mood or just fluctuating normal mood? At which time intervals would you measure that? And also I noticed that it's not in your model anymore in the general discussion, the instability part. So if you could enlighten me on this concept, I would be very happy.
Highly esteemed opponent, thank you for your kind words. You're asking how I defined mood instability. This is very important. Mood instability is only in the last decades become more of a feature in bipolar disorder. Traditionally, people looked at full-blown episodes of mania and depression, but Goodwin in 2016 wrote an addition to the guidelines, and he emphasized that actually people have a lot of instability between these episodes. Now, the way I looked at it was small changes in mood going up or going down. And Mansell had a nice theory in bipolar disorder about what these mood these small changes in internal state have for an effect on the bigger mood states. He proposes that these small internal changes, so if you, maybe this is not the right way to look at it, but if you could define that as a small up in mania or a small down towards depression, only small changes that are actually normal changes in mood that everyone experiences. Mansell describes that they are interpreted by someone with bipolar disorder as meaning something. And that this interpretation actually gives rise to anxiety and all kinds of other explain. He has a whole model that is very interesting. Now that is a little bit what we've...
So it's not really the mood instability itself, but appraisals about normal changes in mood?
I think that everyone experiences changes in mood over the day and over the week. But if they get more pronounced or they get more, have more of an effect on your daily life, they cause anxiety, they are so much, the amplitude is so big that it causes you to have days off work or have to cancel social events, then it actually has more of an impact. But this is a relatively new way of, a new focus. So we asked people, what are these changes? And we measured them daily. We didn't look at an average how was your...
Karin van den Berg, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose that branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. what's on the line. I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Karin van den Berg, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Keizers is authorized to confer upon you the academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer on you, Karin Catharina van den Berg, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signaled by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Dear candidate, dear Karin, 3 weeks ago we drove back from the trial defense, the proefpromotie. I was driving. You were still somewhat impressed by it, still a bit flushed, and on the verge of relaxing, but not completely there yet. And you said, still a bit shaky, that was not too bad. The questions I got weren't that difficult, were they? Well, the questions were about temporal relationships and network analysis, about reliability and coherence of item pools, about mixed linear modeling, and about current directions in pharmacological treatments. I did not respond immediately. I felt rather lost for words. There is something remarkable about you, Karin. 6 years ago, you were a senior clinical psychologist for many years already and working with severely ill patients. You started with the basics of SPSS. That's not too difficult, is it? You said. You learned R. Nice. It is really more extensive than SPSS, isn't it? You went to Oxford for a week to be trained in image-enhanced cognitive therapy. Feels like a holiday trip. You implemented the treatment in Holland with colleagues who had to learn it. That went smoothly, isn't it? You dealt with the medical ethics committee. I expected worse. Paper presentations, that wasn't that bad. Journal editors, are they always that polite? So we drove back from the trial defense and I said, no, Karin, those questions were really tough. They weren't easy because you knew how to respond. And yes, Karin, they were nice people, but it is also because you yourself are warm, attentive, and open-minded person. So at that point, while driving the car, I came to the following conclusion. Karin, you are really one of the most non-neurotic persons I have ever worked with. Maybe not a really poetical conclusion, maybe, but nevertheless, Marisol, not here today, but thinking of you, Drew and I have seen you accomplish things. And of course, Karin, sure, with the help of others, a lot of other people, Mari, Bram, Anna, Govert, Rob, and the Oxford team, with support of Catharina Hospital, and yes, of course. You stand amidst your family and your teams. You wouldn't have wanted it otherwise. but we saw you accomplish things that were really difficult to do. And the most remarkable thing is that you accomplished these things with a really stunning sense of joy and optimism. I do not know, Karin, what scares you. Maybe there are things that do, but you just move forward energetically, meet the challenges, and stay balanced. And you did it again today.
Dear Dr. van den Berg, also on behalf of Maastricht University, I congratulate you with the degree that you have acquired. I also have some practical issues. We do like to take some photos also with the online people. So we stay here a while, but and then there will be, I think, a photo in the hall, in the stair. So I will ask you to already go to the reception hall and there wait for us to come, and then you can congratulate Karin van den Berg. And hereby I end this session.
Oh ja.
Maar weet ik het met die foto's ook niet helemaal, hoor.
Nee, ik ook niet.
Ja, voor het beeldscherm.
Ja, dat denk ik.
Ik denk onder het beeldscherm, ja. Maar ik ben niet...